Well, we actually do have some data. We all have used carefully the word chemo and not specifically which drugs or how much of the drugs. And Wells, why don't you start? There's the PTAC-6 update that's being given at this meeting. A quick summary of what that did and showed.
Absolutely. So this is one of the largest rectal trials that's being presented at the meeting, and had over 1,000 patients. And they either received oxaliplatin or not following chemoradiation. And what was interesting is that overall the trial is negative, so it's sort of a check in the minus column of using oxaliplatin in the setting of rectal cancer. But what's interesting about it is in subgroup analysis, they found that the addition of oxaliplatin had a trend towards harming German patients and a statistically significant benefit for non-German patients. And of course we see in many of these multinational trials or global trials some of these issues. You and I have seen that pendulum swing back and forth a few times in terms of should trials be global and how applicable are results in certain populations. But it's interesting to me that in the non-German patients the hazard ratio is around 0.65, whereas in Germans it was greater than 1.3. So as someone who went from a Messersmith to a Messersmith, I'm not really sure what to do. My whole world is changing because now I found out I have to get a colonoscopy too. So it's been a rough week for me, and I'll do my best to move on. So.
Yeah, so I have been a minimalist. I think as you get older, you get less aggressive, I would think, in terms of treatment, particularly in the adjuvant setting. And I've been not using a lot of oxaliplatin at any point in rectal cancer. Preoperatively, I tend to use capecitabine with the radiation. Postoperatively, I haven't been convinced that there is a role for oxaliplatin in this subgroup of patients, regardless of age, except in that patient that Bert sort of alluded to, is if they didn't downstage or if they didn't really respond very well, I might throw in some post-op, based on nothing. But that. So this is, when I read this result, I'm like, okay, then I'm feeling good. This is good.
Yeah, I should have pointed out, they also found some trends in patients who had that higher risk. So less tumor regression or multiple nodes, there seemed to be some benefit.
So it justified that practice pattern that I was using in patients. Marwan, on the other side, there was a couple of other studies looking at oxaliplatin and different roles. You want to review those couple of studies for us?
Sure. I think one important study that is being updated is the ADORE trial. And I think one thing that is unique about this study is that it's looking at those patients who don't downstage well, right? Because it's looking at patients with YT3 tumors with nodal negative disease or any nodal positive disease, and we know that those patients following chemoradiations don't do well. They have a higher risk of relapse, and those patients were then randomized to receive either fluoropyrimidines alone or to receive FOWARC. And interestingly, on that trial, there has been a significant improvement in disease-free survival in favor of the oxaliplatin arm, with more than 10% absolute improvement in disease-free survival. I think this is, in a way, nice to see. It's a small study. It's a large randomized phase 2. But for those of us who make a case for oxaliplatin in a post-operative setting, at least for those patients who do not downstage well with chemoradiation, I think that is something that supports the use of oxaliplatin in the post-operative setting.
And so I think about that. So that's the issue is that if you've given pre-op chemo-RT, you don't have a Metaport, then they have surgery, then you've got to put a Metaport in and give them some ox-based therapies. I think that's what that's telling me I have to do in that patient. Is that the way you interpret it?
I think so. I mean, I think those patients clearly, they're getting fluoropyrimidine with radiation. They're going to get Xeloda, so your port is going to be post-operative, and then they will get 4 months of intravenous chemotherapy.
The other study, the Chinese study?
Yeah, the FOWARC trial is a randomized phase 3 trial, but it's a small randomized phase 3 trial, and that's looking at 3 different strategies: fluoropyrimidine plus radiation versus fluoropyrimidine oxaliplatin radiation versus FOLFOX alone, and all 3 arms are followed by surgery. And that study, interestingly, did not show any difference in disease-free survival or overall survival. I think what's so interesting about that trial is that the overall survival is actually quite good. At 3 years, all of the arms had more than 90% overall survival. I still don't know what to make out of that study, because all of the arms, the radiation arms, are not conventional chemoradiation arms. Everybody got about 3 months of chemotherapy, and you've incorporated the radiation with those 3 months of preoperative chemotherapy. And then the fluoropyrimidine arm was also not a continuous protracted continuous infusion arm, so it's also not the typical treatment we do. But what's comforting is that the FOWARC arm did well and without radiation, and which basically supports looking at that strategy of no radiation. There wasn't any higher risk of recurrence in the FOWARC arm. The local relapse rates were the same. You would expect radiation to reduce local relapse, and their overall survival was good. So I think that's a point for neoadjuvant chemotherapy without radiation to support looking at that strategy further.